first question is, what do we know about the direct support workforce? That's the first slide in my slide deck, but I want to kind of back up to yesterday, because at the end of the day yesterday, I realized, well, it's really good Sherry asked me to talk about this, because in every single one of the topical areas yesterday, the direct support workforce came up as one of our challenges or issues in our summary conversations. So our work is important, I think. That validated it. We knew a lot more 20 years ago about the direct support workforce than we know today. So that's another piece that I'll share with you, and that's kind of ironic, given that we've been doing research around the direct support workforce for 30 years. But I think at the end of what I share with you, that statement will make a little bit more sense. What we do know, for the most part, are information about wages, turnover, and benefits in many states. So the studies that get done to give us this information are usually done by provider trade associations. Big sampling challenges there because they only look at their member organizations, or they're done by an individual state. So we do know that. We know that on average, across all these studies, when we look at them and try to summarize what's done in them, not quite a meta-analysis in terms of a methodology, that workers make about $9.50 an hour. If you call Sherry or I up, or any of our colleagues, that's what we would share with you. We'd tell you turnover rates are roughly around 50%, depending on the study that you look at. And there's always that catch, because we don't really have a good picture in the United States about that issue. We do have a fairly good handle on what factors influence turnover of direct support workers. So Sherry just mentioned about how important the workforce is in being able to conduct research, because inevitably you're engaging with them. When we pulled together our last center proposal, it wasn't until it was kind of all done that we realized, oh, just about every single study in the center proposal is really about a direct support workforce intervention. So we have a pretty good handle on what influences turnover, and I'll share that with you in a minute. As Sherry suggested, we also know that supervisors are critically important, and part of that is because supervisors and the relationship that workers have with their supervisors is one of those factors that influence turnover. We know that wages are higher and benefits are better in more congregate care settings. So workers who work in institutions, who work in ICFMR programs, intermediate care facilities, who work in nursing homes, and who work in smaller group homes make on average more money, and they certainly have access to greater benefits. We know that in self-directed models, a few studies have looked at this, one conducted by Matt Bogenschutz, who's here, and one or two by me, look at wages. So the picture looks a little better in a model where the person gets to direct where their resources go, and they get to hire their own staff and set wages. Workers make on average about $2 an hour more in those circumstances, but almost none of them have access to benefits or use benefits. So the wage picture is a little better in self-directed models, but the benefit picture is a little bit worse. We've had a number of studies that we've done where training interventions work. If you invest in training and you train the worker, they can develop skills that make a difference in people's lives. And my colleague Derek's going to share with you some preliminary results of a longitudinal study we have right now that's really looking at, in a bit of a sophisticated way, the outcomes of training intervention. We've done an enormous amount of work over the last 2 decades to identify what are the competencies that direct support workers and frontline supervisors need to have. And I'll share with you a study that Lori Sedleski's working on right now that takes that a little bit further. We also know that states by and large, invest very little in uplifting the direct support workforce through training. Over that 20-year period of time, policy changes have resulted in less and less training actually getting delivered to direct support workers. And yet, if you think about that chart that Sherry had up that kind of shows the decline in congregate care services, workers are much more dispersed and they're getting much less support and training for what we're asking them to do. We also know that workers have very little voice in anything, in policy, in practice, in virtually anything related to all those outcomes that we've been talking about. Our system isn't set up to turn to them first for information and intervention. We also know what it takes to reduce turnover. We've had a number of studies that we've actually demonstrated you can take a 70% turnover rate and whittle that down pretty substantially, and I'll share a couple of those studies with you. Whoops, going the wrong way. So here's what we don't know. I can't tell you today how many direct support workers are employed in the United States supporting people with intellectual disabilities. The only study that was ever done related to that was David Braddock's study, and that was based on 1990 data, so over 2 decades ago. We have, at best, crude estimates. In the United States, the Bureau of Labor Statistics does report occupational categories, but they basically take, I think it's 16 occupational titles, some of which include our workforce, people who support people with intellectual disabilities, and they're chopped up and put into these 16 different categories. So we really don't know. And we don't know ratios anymore. If you look at, we used to have a formula that we used. If you look at that trend line with most people receiving services inside their family home, we really don't know what that ratio is anymore. So we can't tell you that. And from a national perspective, we can't tell you what average wages and turnover are because we just don't have mechanisms and we haven't funded studies to show that. So we have also no longitudinal trends, which I think is really important on not only the descriptive data of this workforce, who they are. We kind of know, well, in our individual state studies, the demographics of the workforce is changing. I used to say it was 24-year-olds, and now the average worker is more likely a female in their mid-40s to mid-50s. So we know we can predict that those things are changing, but we actually do not have any methods of studying that and talking about it with any kind of rigor. It's at best guesstimates. Another thing we don't really know are the differences across service types based on the size and type of service that's delivered. So based on old data, very old data, we can say, well, we know workers in employment services are paid more and have less turnover, but beyond comparing employment and residential, when you start to get into all those models of residential services, we really lose our capacity to talk about the differences in the workforce, the workers in direct support roles, and we don't have capacity to do comparisons across states. We also don't know what policies in a broad way make changes related to the direct support workforce. I'll share a couple of examples with you where we know they do, but in a broad sense, we really don't know when we change Medicaid policy broadly, how does that affect the workforce and what are the changes and the needs of the workforce. And then we are unable to really quantify the differences between long-term care sectors. And this is a big issue in the United States because across states, people are merging and blending policy related to long-term services and supports across mental health, aging, intellectual disability, and brain injury. Those workers, we know, we have a hunch that they need to have different skills and different competencies, and they have different issues and do different things, but we really have no way to describe the differences amongst those workers. We also know from our work that you can intervene on the workforce or make change with the direct support workforce in a number of ways. So I'll share with you a couple of systemic examples where you can make changes based on policy-related things by focusing on organizational leadership and practices, and then through, Derek's going to talk about the monitoring individual outcomes. 2 slides here that talk about how wages or big systemic changes can make a difference. So this was actually a study that John Fortune did, who's now with HSRI, but at the time was in Wyoming, where the state purposefully did a wage increase for workers to see if it reduced turnover. And wages matter. I mean, it showed that if you overtime pay more money, turnover will go down. Here's a similar slide that shows how wage influences turnover from the state of North Dakota. Another intervention that this actually came out of Sherry's dissertation work is related to realistic job previews. One of the things that she found in her work was that if workers don't have a realistic picture of what it is they're going to be doing in their jobs as direct support workers, they're more likely to leave early within that first short amount of time. And so some of our work related to interventions has gone into developing tools and resources that give people a good picture of what it is that they're going to be doing. And Jerry, our video person back there, has produced a number of these. We try to keep it updated so that it's a tool or an intervention that organizations can use broadly to give information to job applicants about the job and about the work they're going to do before they actually take the job. And that's been shown to reduce turnover rates by up to 18% in our work. So it's an effective strategy. When I first put the slide deck together, I could talk about this being one of the best examples in the country around a broad-scale intervention. I learned after I put the slide deck together that the funding for Kentucky Speaks was completely annihilated recently. So a wonderful example of how organizations came together, created a realistic job preview for their workers, and it had a tremendous effect. You see the kind of bar graph on turnover, but also a wonderful example of how it's very difficult to sustain any kind of systemic intervention around direct support workers. As I mentioned, we're increasingly seeing this mix together, this coming together of the long-term services and supports workforce. We're engaged with the Centers for Medicaid and Medicaid Services Direct Support Workforce Resource Center and have been for the last 7 or 8 years. And I think there's some interesting parallels to the work across sectors and across service types, but there's also some unique differences. So when we talk about direct support professionals, we're talking about agency-based providers, individual providers, so that's people who contract with the state and they get really an employee ID provider number, and they deliver the service and they're paid by the service vendor. There's no organization. And then we have self-directed models. It's really hard to find people who are providing work in the self-directed models. So a lot of the methodological things we've talked about today get harder and harder as we move away from organizational-based research. So when we do our research, the way we get to workers is through organizations or agencies. Every single one of the studies we've got going on right now at the University of Minnesota, our entry is at that organizational level. But if you look at the trend line of services, people are increasingly not getting services through an organization. That's a significant issue for us methodologically and how we gain access to the workers. There's also an increase in the use of informal support providers, so family, friends, neighbors. Are they really workers or are they not really workers? Do we have the same expectations of informal caregivers as we do of workers? Would we expect families to be able to implement a methodology like active support? Is that reasonable to expect or not? If we want to test out those interventions within family systems, we're going to have to figure out how to do that with informal support providers. And then we have paid support, and that's a new trend in the United States. I don't know about internationally how broad-based that is, but now we've blended these models, and informal caregivers are getting paid to do direct support work, but are they really the same workforce? And we don't know. I mean, we know they're different people. They have a different kind of relationship with the person with a disability, but we really don't know anything about that workforce specifically in intellectual and developmental disabilities. Then we have kind of this whole new group of workers, transition coordinators, options counselors, support brokers, peer support specialists. These are emerging groups of direct support workers that we really know very little about, and very little about the similarities and differences in competency expectations and the kind of work that they do, but it has significant implications for all of the outcomes that we're trying to measure, because these folks are involved in that service delivery to the person in some way or another. In terms of monitoring the workforce, we're getting better, but again, we have no systemic national way that we're looking at issues related to volume, which is really the number of direct support workers, which I talked about, and the number of part-time workers, and that staff ratio piece that I mentioned. So I think if you asked most any of us, we would say there are fewer full-time workers in the field now than there were 20 years ago, but we really don't know that because we don't count, we don't measure. We presume that. We look at turnover rate. Most often we measure this through accrued separation rate, and then we also look at vacancy rates. So how many positions are there open that need to be filled where there's not a person to fill those? And we've talked about compensation related to wage, health insurance, and paid time off. There are a handful of states that are going through a demonstration with us through the DSW Resource Center right now that we've created the instruments, the tools, and we're trying to work with them to implement a more systemic way of gathering this data. It is very complicated because they're trying to do it across the long-term services and support systems, and they're very siloed. So it'd be interesting, it's interesting work to watch. The work that I mentioned that Lori is doing related to core competencies, 20 years ago we were working with HSRI on the development of the community support skill standards, and very little's been done since that time to update the community support skill standards and to reflect a more contemporary set of competencies. Simultaneous to that, you've got other sectors, mental health, aging, substance abuse, who have an interest in the direct support workforce. And so we're trying to create a set of core competencies that would be required of all workers across those sectors in this work. Our approach to that has been to look at the existing sets of competencies across those sectors, determine whether or not there are similarities across those sets, and then begin to, through a content analysis process, bring the sectors together to identify a core competency set. These are the folks that we're working with, this slide gives you an idea of the similarities across the existing sets. So we looked at a number of sets, and there's quite a bit of congruence which would indicate to us, yes, there is this set of core competencies that direct support workers need to have. At the same time, there likely are specialization skills that workers who are supporting people with intellectual disabilities need to have that they might not need to have in other sectors. The most blatant example of that in our work is in the area of training. And in intellectual and developmental disabilities, we expect workers to teach people with intellectual and developmental disabilities new things. It's a part of the job expectation. But in aging services and in mental health services, that doesn't rise to the top in terms of a core competency, because they don't really expect their workers to actually be teaching and training. So it's an example of, it seems intuitive that in caregiving and direct support work, there would be a set of skills that go across all of those sectors, but it's not necessarily the case. Another area where we know that it makes a difference through our work is frontline supervisors related to direct support turnover. And this goes back to Sherry's work related to her longitudinal study of direct support workforce turnover. And a lot of people leave early, and the reasons that DSPs leave, two of them that we talk about a lot really have to do with frontline supervisors. So issues with coworkers, supervisors really are the mediators around issues with coworkers, and then also either a lack of supervision or challenges with supervisors. So it gives us kind of, in our intervention work, a place to go. We know we can make a difference if we can get stable supervisors who are competent and understand how to support direct support workers. In the late 90s, we developed a set of frontline supervisor competencies. The broad competency areas are listed here. And then in our last cycle of the Research and Training Center, we took those competencies and did a national validation of those competencies. And then from that work, we're working now to produce a contemporary kind of knowledge translation of those competencies into a national frontline supervisor competency set. And these are the 11 competency areas of that work. When I think about all of the workforce research and knowledge translation that we're doing, where we're really lacking is in the individual people who live in their individual homes or in their family homes, and the workers that are influencing and supporting those individuals. We haven't taken our workforce development work to that service type, and I think we would, my prediction is we would find pretty significant differences in needs and issues in those settings. Related to training, and then I'm going to pass it off to Derek, we make a lot of assumptions about training. There are a few things we do know, but we mostly make assumptions around training of this workforce. The things we do know are some training challenges related to inadequate training can affect direct support workforce outcomes of whether people stay or don't stay, whether or not they have greater workers' compensation claims or critical incidents. We have pretty good information about that. We know that workers report to us repeatedly that they have limited access to training and to high-quality training, and that the training that exists for workers is usually prescribed in policy by training hour or by topic. It's not linked to competencies. And we assume that training makes things better, which I think is a reasonable assumption, but I'm going to pass it to Derek, who will talk about a study we've got going on that's trying to take that beyond an assumption.